Hello viewers, today I am going to show you a surgical approach which involves fixing a medial tibial plateau fracture with a medial approach. Now the two common approaches that are used are medial or posteromedial approach. So today I am going to take you through a medial approach for a patient who has got a medial condyle fracture, and I'll take you in a step-by-step fashion as how to do this approach. Now you guys have been requesting a long time for approaches of tibial plateau, and I will try my best in next few months to cover all these approaches one by one. So these are this gentleman's X-ray. If you look at the AP, there is a fracture of the medial tibial condyle and there is associated fracture of the spinous process, and the same you can see on the lateral. So there is some articular irregularity, also there is widening and there is a huge gap. So if you follow the classification system, I think most of us follow SCAT's classification, it will be type 4. Whenever there is an involvement of medial condyle, always think of knee dislocation, and examination of peripheral pulses and common peroneal becomes must. So these are usually associated with dislocation. Now if you see the lateral, there is no posterior condyle. There is a recent classification of LUO, L-U-O, which says the 3 classification system, and I must say that if you're dealing with tibial plateau fracture, you must read about it. So the apex is here, apex is here. So on this equation, we don't need posterior medial plate, we just need a medial approach and then buttress this. So I'm taking you through a medial approach today, and I will show you how to do a buttress plating in these fractures. So we are ready with our theatre setup. So patient is supine, we have given tourniquet. I think there's no real disadvantage, but there are a lot of advantages of using tourniquet. Patient is lying supine. The C-arm is going to come from the other side. I am going to stand on this side. My trolley is going to be on this side, and this is my theatre setup. Now the next step will be to show you the skin markings for this approach. So few important landmarks. So this is the femoral condyle, front and back. This is just a rough representation of femoral condyle. This is where the shaft is going, roughly there. This is the center. This is the joint line. This is the posterior medial border of the tibia. So I have drawn the posterior medial border of the tibia, something like that. This is the anterior border, something like that. Now you just keep the knee slightly 15 to 20 degree flexed. Now if you are using a medial approach for a medial plate for this fracture, because mostly the fracture is in the sagittal plane and the posterior part is very little, so we don't need to buttress the posterior part. That is why we are using this medial approach to buttress the medial fragment. So for posterior medial approach, your incision would be something like this, just going parallel to the posterior border. But for this, you can, in the books you will read start above the joint. I don't intend to open the joint, so I am just going to remain below it, but you can start above and you want to be in the center. So it will be slightly more anterior than your conventional posterior medial approach. So this is your skin incision, and you can use it depending upon how far your fracture is. So I'm just going to C-arm shoot, see where the apex is, and decide my length of incision. So we have looked at our C-arm and our fracture line. The apex of the fracture is somewhere here. So I don't think I need to be more distal than this. So I'm just going to use this much incision, and if I'm struggling, I can always extend it more. So you can make your incision bigger, but you cannot make your incision smaller. So let's start with skin incision. So the tourniquet is inflated. Yes, okay. So let's start. I'm not planning to open the joint, so just stay close. Now there are two important structures which can be injured in this approach is saphenous nerve and the saphenous vein. So I'm just going to put my self-retaining retractor, achieve some hemostasis, and then I will join you. So I'm just putting my finger, and I think this leg is extremely swollen, but our incision is pretty good. So just layer dissection, change your knife, layer dissection. Now normally when you read the approach in books, then you find it very easy, but when you come to the real life, things are not that straightforward. Can you see the amount of hematoma here? It is very difficult to identify what is what. So I'm just taking a knife. Now the first fascia that you find here is the crural fascia. So I'm just going to divide this both proximally as well as distally. Now in high energy injury, sometimes all these planes that you read are destroyed. But key is, even if you don't identify the plane, you keep on going, stay close to the bone. So far I have not seen anything important. I have not seen the saphenous vein, I have not seen the saphenous. Now usually they are little bit on the back, so you don't always see them, especially in this approach. But when you are doing posterior medial, then there is a good chance you might find it. So let me continue my dissection. So once you see this shiny structure, this is the pes. This is what when we are doing ACL, we dissect this and try to identify the different tendons and then do it. So I'm just going to raise this flap on top of the pes, and it's not a bad idea to just use a swab and give it a good swipe. So just a good swipe in the back and good swipe in the front, and then you start seeing this shiny structure in the front. So this is all pes. If I can have my dissecting scissor just to show you, this is the pes. Now your plate has to go deeper to it. So I can see the lower part of the pes, the tendinous part is here, and everything else is just, this is just the fascia. So I'm just going to open this fascia right onto the bone and see if I can create a tunnel. Or the other option is you can skeletonize, you can identify the tendons and then try to mobilize it, but you will have to mobilize it. However, if it is coming in your way, then you can just cut it, tag it and repair it once you have put the plate. So I've just opened the fascia just below the pes, and I'm just going in line the way you do when you are doing your ACL. So this is also just thin sartorius fascia. So I just have got, and if I can have a Langenbeck please, let me see if I can mobilize my pes. So I'm not planning to skeletonize it. This is the usual. When I need a large Hohmann, they always give me the tiniest one, and when I need a tiny one, they will give me a big one. Anyways, we have it now. So you can mobilize the pes, and once you mobilize the pes, then you go onto the deeper layers. So let me reposition everything, and then I will use some periosteum to identify the fracture site. So far let's start. So skin incision, fascia, crural fascia, opening of the sartorius fascia, and then you have this pes. Pes has been mobilized. Now you're right onto the bone. So you see this, can you see this structure? This is the MCL. And if you want to open the joint, if you are one of those surgeons who believe in seeing everything through the eyes, increase the incision, make a vertical incision, and then you can do an arthrotomy here, lift the meniscus, and you should be able to see the joint. However, I feel it's unnecessary, and I don't open the joint, especially on the medial side. Lateral side, yes, always, because lateral side is the weaker side. You see a lot of comminution. Medial side is the stronger side. The articular surface is usually not comminuted, so I don't see any point in opening the joint and adding to the morbidity. So I'm just lifting this up, and then if I reposition this, I can start seeing the fracture site. So this is the apex. If you can see here, can you see here? This is the apex. If you can have a Langenbeck please. And Prashant is pretty good in doing camera work and otherwise as well. So if you see this, this is the apex. Now once you are on the apex, we are on home ground, isn't it? Now all we need is, we can use something like a clamp and to reduce it, and once we have reduced it, we can use a plate in a buttress mode. So let me just do a little bit of more dissection, clear this up so that I can, if I can just clear this up slightly so that I can see the shaft. That's it. And then I'm in a position to do my reduction. So if you can see here, this is not that displaced. But the most important part when you are doing it tibial plateau is to reconstruct the height of the tibial plateau, let it be medial or lateral, needs to be restored. We focus too much on articular surface, but it's the height, and especially if you're dealing with bicondylar fracture, reconstruct the height, fix the medial condyle first, and then move on to the lateral condyle. So let me just reduce it, and then we will show you how we fix it. So now what we have done is we have used a clamp. You can have a king tong clamp. This is a clamp from our pelvis set, which we have compressed, and I'll show you how it looks on X-ray. So if you see here, there is a gap here. This is much more open. Now when you see here, once we have applied the clamp, you can see this gap is almost closed. The articular surface is almost restored. The height, which I said is the most important thing, height is nicely created. There is no sag. Now I think I'm just going to use few K-wires to hold this in position, and then once we buttress it, I expect this gap to even get minimized or almost get closed. So now we have passed about 2 wires to provisionally hold our articular surface, and once you are done with this, now we are going to take a suitable size plate, and then we will check this position in AP and lateral, and then we'll use it in a buttress mode. So once you have passed the plate, you can see the plate is going underneath from the pes inserenus, and I am going to check my position on AP and lateral. You will see I'll deliberately put the wire especially more posterior, because if you are putting it in the center, then plate will come in the way. So once you are using provisional K-wire fixation, either put posterior or anterior so that you have got position or free space to put the plate. So now we have checked the position. The height of the plate looks okay on AP, and even in lateral the plate looks pretty central, and I have checked distally as well to ensure that it is in the center of our shaft, and we can see the distal part anyways. So you have to ensure that plate is in the center on the lateral. That is extremely important. Now since we are using a simple 4.5 T plate, there is no holes for the K-wire. We have used one of the guides, and we have used a drill to keep the position so that height doesn't change. Now here we can see it, this is in the center, so I'm not worried about distally. So once we have decided our height and we have already checked, we are just going to put the screw just below the fracture apex, and it will be a simple 4.5 fully threaded cortical screw. So now we are, you can see this is the height, this is the screw closest to the apex, so we have just fully drilled it, and then we are going to replace it with a suitable size screw. So now you can see we have compressed our apex, and the fracture is almost nicely reduced. You can still see some fracture gap, but I think that is all going to fill up. As I said, the most important thing is the height. The height is maintained. The intercondylar eminence is now nicely fallen. There is a millimeter of gap here. We will see if we can get some partial threaded screw. Otherwise, even if it heals in this position, it will be absolutely perfect. So this is, we have put this apical screw, then we have put these 2 screws, and you can see the plate position is just under the pes on top of the deeper structure, the MCL, and now it's just a matter of filling up the screws. The advantage of using this normal is that you can use a partial threaded screw. So we will use few partial threaded screw from here and here to see if we can create some more compression, and I'll show you how it looks. So now we have used a partial threaded screw, and it's a really good bite. So now we are putting the second screw through the T plate. When you are using the plate in buttress mode, you don't really need these screws, but because it's an intra-articular fracture, we're just trying to compress it and gain some more compression if possible. Otherwise you can, you don't have to necessarily fill it, but we are going to do a good compression here with these 2 screws, and then I will show you how it looks. So you can see now the articular surface is nicely reduced. The tibial spine is also fallen in place. You may find some gap at the apex, but that will fill up. We have supported the fracture really nicely, and this patient you can start mobilizing from day one. So let's do some final compression and tightening all the screws, and then I will share you some final images. So these are our final pictures. This looks pretty good. I am happy that the height is pretty good. So there is no sagging of the medial condyle. If it sags, then it leads to varus and it can lead to a lurch, but the height is pretty good. The tibial spine has fallen back in place. Laterally, again, you can see the height is nicely restored. The plate position is okay. It could be slightly touch anterior, but when we look, it's just the view, because when we are looking live, this is bang in the center. So this is a good job done, and then we will start closure up after wash up, and then he will start mobilizing his knee from tomorrow. So this is our final position. This is our T-plate. These two are partial threaded screws. These are fully threaded screws in buttress mode. Now it's just a matter of approximating these structures like this, and then I'm just going to use a vicryl, and then we'll do a layered closure. So I'm starting with this corner. I'm just using a number 1 vicryl, and then I'm just taking this. Now you need to restore the anatomy, and you will be able to restore the anatomy only if a dissection is in layers and you have identified the layers. So once you have identified your layers correctly, closure becomes a piece of cake. If you are, I'm sure, if you read about, one thing I wanted to talk about is, if you read about classification system, most of us follow the Scatchek classification from 1 to 6, but there are newer classification which are based on column, especially the Luo 3 column called classification. So if you do tibial plateau fractures, then you must read about Luo's classification, or the newer paper from Scatchek which has been published recently, which talks about the posterior fragments as well, because in initial description there was no mention of posterior condyle, and you will see in your clinical practice that you see a lot of posterior condyle fractures. So read Luo classification. I think it's a must if you're dealing with tibial plateau fracture, and also the newer classification of Scatchek which talks about split wedge fragment. And once you have got a thorough understanding of split wedge fragment, you will be able to do a better job. And I think my treatment has improved because now I know that reconstruction of height is the most important thing. Articular surface, because once you reconstruct the height, you recreate the mechanical axis, and once you recreate the mechanical axis, your results will be good. If you have done a good intra-articular reduction but your height is not good, patient will never have a good result. So if you can see here, I have beautifully closed it. Can you see it now? The plate is nicely closed, and if you at all manage to accidentally cut pes, or it's coming in your way and you're getting frustrated, you can cut it, but in the end you need to repair it. If some gentleman can use a Langenbach and show me the apex, that will be great. So this is what I wanted to show actually. Once you have done it, it's pretty straightforward. So let me do this closure, and then I will show you how it looks. So whatever we cut, we have recreated it back. Now it's just a matter of closing our straightforward dermis layer. So I'm just going to run a continuous stitch, and then I will use either some ethylon or some skin staples. So this is our wound beautifully closed. So we are just going to apply some G-dress, some pressure dressing. I keep them in ROM so that they can start moving their knee from day 1. I will start weight bearing from roughly around 6 weeks. So viewers, this was a demonstration of how to do a medial tibial plateau fixation using a buttress mode. On this occasion, major fragment was sagittal, so we used a plate on the medial side, hence we used the medial approach. There will be occasions where we will be required to use posterior medial approach, and hopefully in due course I will post the video for that as well. So I hope this video helps you in your practice. The key is the plate should go under the pes, and try to preserve the pes and respect it, and if you manage to cut it, repair it in the end. And once you have done a good job, don't put them in plaster, get them going from day 1, especially ROM. You can deal with the weight bearing if you wish. So I hope you find this video useful. If you find this video useful in your clinical practice, and if you like this video, please give us a thumbs up, please do subscribe and do share our channel. Thank you.